So, good morning, my dear students from Delhi, Jharkhand, Tripura, Assam, Manipur. Welcome. So, today we will be talking on a very important subject that is on DSS, dynamic hip screw. So, we all know this is one of the very important subject, and probably this particular area of the flexors around the trochanterus is one of the most important subject. So many things have been coming up, so many things have been discussed, and there is so much evolutions on the concept of the trochanteric flexors. Is still is a matter of very controversy, a matter of very concern to the orthopedic fraternity for the world. Well, so as you know, we start always with some philosophy. Philosophy is today is Nama Karmani Limpati Nama Karma Phalespiha Itima Jud Bijanati Karma Bhinna Saviddhate. Means that those are devoting their work without any expectations are not being bounded by the karma reactions. So you are not binding with these karma reactions. You know, the one who does his work has to feel he gets the results, and also he had to have the reaction. So one who is devoting work without any expectations or results, Nama Karmani Limpati, Nama Karma Phalespiha, Itima Judpi Janati Karma Bhinna Saviddhate. That is from Gita. Chapter 4. This is an important topic. So that is what says that you do devotions in work without expectations of results. Well, then we will go ahead with the DSS. You all know, as I said, DSS is one of the topic which is evolving. So many things are coming up for the trochanteric flexors. Probably it was one of the subject that is always gives stimulus for the orthopedic surgeons throughout the world. And you know, with the increasing number of the aged patients, longevity of the persons, also that leads to your increasing number of the fractures around the trochanterus. As you know, this is most of the time it is insufficiency fracture or the fracture related to osteoporosis, related to orthopedic elderly persons. And there is so many controversies, so many things, so many evolutions, so many concepts are coming up. Every day some new things are adding and some things are going away from the field. That is a continuous process happening for last many years, many decades. As you all know, that in around 1940, debate was on that what sort of treatment should be given. Should I go for the conjunctive treatment or for the operative treatment? Now the thing is settled that it is the operative treatment that is more important. The principle of treatment in osteoporotic trochanteric fractures is that they give the fixation, do the fixation as early as possible and mobile the person as early possible. As long as these persons are mostly osteoporotic, elderly patients, and if you do confine the patients long in the bed, it will give a very detrimental outcome to the life of the person. The mortality rate is high, the morbidity is high, there's so much things are coming up, the problem with respirations, the bed sores, and so many things will come up. So today's concept is that do early fixations for the fractures, and it is possible to mobilize the patient as well. This is the basic principle and treatment of this treatment of trochanteric fractures in today's scenario, and keeping in mind how the DSS is going to help us to fulfill our ambitions of mobilizations, early mobilizations of this special category persons. We are going to talk about that. It is a matter of concern that in 1940 or subsequently, sliding hip screw has come to this field, and a classification of trochanteric fractures, mostly by Evans classification, is today's scenario. Today's scenario is already being settled. So today's scenario is already being settled. So we all know is it stable and unstable fractures there. And sliding hip screw is coming into the field of fixations. But subsequently in the era, it is seen there so many complications are arising from this sliding hip screw also. That is why, though in earlier period there was a boost or there was a stimulus for the orthopedic surgeons to go all the trochanteric fracture for fixation in the DSS. Now, it has been seen that not all the cases can be addressed with DSS, because it leads to some sort of complications which is not desired. So that is why in today's scenario, that DSS is being done in only those cases with stable fractures, and certain fractures we need to exclude. We all know about the stable and unstable fractures in context to the Evans classification, other classifications, or even our classifications. But we, instead of going for the all details of the classifications, we try to confine ourselves the indications and contraindications of DSS, where we can do, where we should not do. That is more concern rather than going for theoretical discussions about the various types of merits and demerits of various classifications. No. So we are let us concerned about the most practical aspects, that where we should do DSS and where we should not. As long as DSS is concerned, one thing is true, that DSS is basically a tension band plate fixation. Tension band plate fixation. So DSS is basically a tension band plate fixations, and to adhere to the principle of tension band plate fixations, we try to understand that in adhering to the principle of tension bending, you must have the integrity of the medial cortex. So if you are applying the plate from the lateral side, that means we must have a good contact in the medial side. That is the principle. So that is the desire, as long as the principle of your tension band is concerned. So necessarily in those cases where there is fractures on the medial part, posterior medial component, integrity is lost, is not a good case to go for the DSS. On the other hand, if the lateral wall is also fractured, and if the plate is going inside and the compression is not going, instead of plate moving, that is not a desired thing. So there are two points are coming up. Another point is that there is the reverse of the fracture. See, the fractures which are reverse. We all know the reverse and reverse fractures, the importance is that the understanding the basic mechanism, in fact, that the muscles working around it, the adductor muscles working towards the medial side, the abductor muscles working over there, there are two different directions muscles. If the flexor line is like this, so there is the distracting force is working over there. If the flexor line is like this, same distracting force will now exert compressive force. So necessarily, while the flexor line is like this force is working like this, that force is working like this, it will let a gap, there is a shearing force working, it is not a good thing for the DSS. On the other hand, if Evans classification is concerned, those persons who after reductions you do not find is stable are a case of unstable fractures. So these are the four category of persons which are not suitable for DSS. So that is why in those cases, if you do apply these principles where it is not desired by principles, should not go for it. Otherwise, we will have to face a lot of problems later on, and cut through, working failure, sometimes displacement is there, sometimes varus deformity is there, shortening is there, so many problems may come up. So we now narrow down the indications. Earlier, though the concept was there to go for any sort of fractures, no. Today it is limiting. So the unstable fractures to be addressed by some other models of tools like the intermediate fixation, PF, and other things are coming up. So now let us talk to the DSS. Now let us talk to the implants part as such first. That it is a barrel sort of your compression here. There are two techniques here. There are one fragment is compressed here, another fragment is here. These two fragments are designed in such a way that there is a compression taking place entity together. So one fragment is fixed here, another fragment is fixed here. They are coupling together like this, and once you do that is basic working force around working over there, the muscles working over there, they will lead to your compressions at the flexor side. This is what is the concept is. Now to have this, we do have the implants. Let us talk about these implants. So what is this screw? The head screw or the research screw. You do have a threaded part over there, which is around 22 mm. The circumference of this is 12.5. 12.5, 22. Then this barrel, this part is around your say 8 mm diameter, 8 mm diameter. Then your propagation, see these threads are very big. And once you do the threaded two part is known as the pitch. As you all know, the pitch is there. This pitch is around 1.3 mm, 3 millimeter. And if you turn one, then it goes around 1.8, 118 mm propagation is taking place. So this is the basic things here. There, the diameter, the length is 1. On the other hand, if the plate is concerned, the plate, we know there are two types of plates. One is your short barrel plate, another is long barrel plate. We'll talk where to select shorts, where to select the long barrel plate. We'll talk about this. Important thing is that the angle. Let us talk about the angle of this plate first. Why this plate is angled. The plate is angled by around 135 degree here. But it is true that it is not always that always you have to select for the 135 degree. The basic concept in selecting the plate is that we try to fix this screw in bull's eye. Matlab indicates that you are supposed to be central. So, you know, while you talk about this plate, let us talk about a little bit of this thing also, the angle. They have now CCD, caput column diaphysal angle. The caput column diaphysal angle to 125 to 135 sort of thing. Sometimes variable. You also true in the fact that this in the osteoporosis fractures, you will find that this angle may come down, it's less. And also if you do observe the various types of X-rays, you will find somewhere the angle is somehow the straight line sort of thing is going more. That indicates that everywhere this is not going to be applied. So CCD is important, though convention in on average 135 degree, but it's true. Now in certain cases it is less, certain cases it is more. That is been seen. If you see a lot of excess of pelvis, you will find the angle is not same in all the cases. It happens to be a case supposing a person whose X-ray is preserved with you at the age of 30 years, and if you do the same X-ray say around 80 years, probably there will be less angle in this case in same person because of the osteoporosis factors. So there is a variability of this here, this is true, but our thing is that you are supposed to have a central of this. To have this central, there are two things. Either you have to change the metal angle or you have to change the angle here. Yes or no? So accommodate this thing while the one reduction is there. To maintain this one, so you have to negotiate. You cannot negotiate with this. You have to change the angle. So that is why they sometimes 130, 125 like this, and again 140, 135 like these plates are available. Now this is basically the idea that you want to place this plate in a central way. That is why the sources changes are there. Though on an average, in other cases, we do apply 135 degree. But this is also actually not the truth. Truth is that if you do consider the here weight bearing zone, weight bearing axis, it is around 150 degree. So that means if you want to place the implants in the axis of the weight bearing, that is supposed to be around 150 degree. But why you are not selecting them? You are not selecting that to place this plate in 150 degree, you necessarily have an entry point somewhere down below the subtrochanteric region. So if you do apply a plate here in the subtrochanteric regions, this is a potential dangerous area where it goes for fractures later on, subtrochanteric fractures. So that is not the ideal zone to go for it. That is why we do select the plane which is somehow at the lesser trochanterous entry. The entry point is somewhat at the level of lesser trochanterous. On the other hand, what is the correlation with the entry point with that of the change of angle? You know that every angle 5 degree, we do have the change of angle in 5 degree. 5 degree corresponds to the 5 mm of the change. That means if you have selected a plate screw here 135 degree here, the point is here. If you do go for a plate for 140 degree, you have to necessarily come down of 5 mm. That is the entry point of that. Likewise, if it is 130 degree, then you have to go 5 mm from the points which normally you use at the level of lesser trochanter. So that is the change of your entry point in relation to that of your plate angles, and we have already discussed why we have changing the plate angle. So it is actually basically to place it in central part. Basically, idea is to place it central. That is why you have to change according to the angle of this air. On an average, it is 135 degree. Number 2 is point. What is the point of selecting the barrel? See, we do have the two barrels available. One is called short barrel, one is called long barrel. One is most of the time 38 mm and another is around 25 mm length. Now, why there is selections here? Now, the important point is that while you do couple here, to have this efficient compression at the fracture side here, necessarily to play this screw, we must have a gap in between these two. So necessarily you must have this. So if it is stucking here like this, so necessarily no place to go for the compression to play. So if it is so, you are not having this desired compressions at the fracture side. So to play this to efficiently have the compressions or control curves, you necessarily have a gap between these two to have efficient compressions. So maintain this gap, you must have supposedly around 22 gap. That is one. So necessarily if the screw is short, the neck is short, you necessarily go for a shorter screw. And a shorter screw, to have this your efficient compressions between these two, necessarily you have to select a shorter barrel. Shorter barrel. So that is the importance. So if you select a long barrel in a short screw, probably you will not get the compressions, efficient compressions in two fragments, and your principle is failed. So that is the idea behind this, how much you need to play between these two. On the other hand, what is the length of the screw? You have to see. The important thing that in between these two, that if your plate is like this, only this part is being inside this barrel, this is not a very good construct, because they will be striking and it will not play. And that is why you must have at least minimum of 22 inside. So here 22 inside, otherwise the coupling is, if your only coupling is like this, okay fine, then your angulation is like this, not going to play. So selections of this screw have to adhere to all the principles we have discussed. The selections of where you have to select short one, where you have to select this long one, and what is the size of the screw, and on what principle you are selecting the screw. All determines, or with this all the principles you have to adhere, and accordingly you have to select the length of the screw, length of the barrel also. Another point is that, do you have any sort of modification to the plate? See, these plates are basically, they are also somehow plates are coming with a round hole plate, or sometimes even a DCB plate. DCB plates have another additional point over here, that we can give a compressions with the DCB principle. So we can have a compression of the DCB principle. One. Now, next point is that somehow. So plate is there, round plate, then there is oval shaped screw. This oval shaped screw also have additional benefit with that it can go back additional compression of the fracture side. 1 point. Sometimes you may find some sort of plate having some sort of outboard like this. This is also important sometimes to have good pulses in case of osteoporosis. Another point is that sometimes you can additionally apply this plate to give a lateral support. Sometimes if you, on the process there is a fracture there, then you have to additionally couple another plate here to give a lateral support to trochanteric fractures if there is a fracture happening. On the other hand, what is the length of the plate you are going to use? There is another point. Since we are talking about the selections of the implants, then we talked about this thing also, how much length we are supposed to select. As such, only 2 screws are enough to in a stable type of fractures, while quality of bone is good, bone fracture is good, and stability is good. But in situations where the bones are very osteoporotic, probably we should select a longer plate. And also if there is a subtrochanteric extension sometimes you may need to go longer plate, but on average, simply if subtrochanteric stable type of fractures or basis trochanteric fractures, probably 2 screws are enough to hold. So that is about the implants, the selection with the screw. Another point we have to talk about the screw. This is a compression screw, we all know. So now what is the role of this screw? Now this is again coming with a short and long, 28 and 29 and 38, 29 and 38, 29 and 38. This is also dependent on what the length, but length is short and long, both are coming up. And what is the rule of this screw? Now this is the compression screw. If you are to apply over there, at the time of operations, it essentially gives a compression at the fracture side of 5 mm. 1 point. Number 2, is it always essential to apply? Certainly no. In says that it is not very important, but in situations like that, like your paralytic patients, here there is a possibility of displacement. So in these situations it is important to apply, but otherwise it's in stable situations it is not essential to be applied. So that is another point. The size, the screw, the effective, how much it is going to exert compression at the fracture side, we have discussed. Now the next point is that let us talk about the techniques. So techniques is that patient is in the supine positions, tractions. Many a times some surgeon used to give tractions in the axis of around 20 degree or 30 degree flexions of the knee joint, hip joints, that gives some additional benefit of stability. 1 point. And applications of the traction in the other limb is also important. Probably in those situations where the patient is very heavy and is bulky man, if you give tractions in one side, on the fracture side, probably the body may shift to the other side, that side, so it may cause some different difficulties in performing the operations. So opposite side traction is sometimes important, but it is always keep in mind that you must have a good assess with the help of your C-arm, so that it can easily play. It should not come in between these picture in the techniques. 1 point. Number 2 point is that in those situations where the fracture is a bit old and you need to exert more compressions, traction, probably in this situation also one should apply traction on the other side, because if you do apply too much traction to the one side, fracture side, the patient bodies may shift to this side, so that may also cause some disturbance. So applications of traction on the other side, and or keeping the other side in flexions, as you saw, it is the thigh support, or application of the traction both sides, logics, and also the same side, and the positions of the hip flexion extension important. The reductions, it is most of the time the trochanteric flexors can be reduced to tractions and interrotations most of the time. But important point always to remember that in the flexor technique we must have a very good reduction of the flexors. This reduction of the flexors, if it is not achieved by simple traction and interrotations, it is not accepted. One may need to go for open reductions if necessary, do the reductions, and can be hold these flexors with some additional screw above or down below, or anteriorly, K-wire fixations, temporary fixation, or even if necessary bone clamps to hold the flexor side. Because if we are unable to achieve a good reduction of the flexors, we will not able to pass a good plate fixation also. So it is paramount important that you must have a good reductions of the flexors. If necessary, go for open reductions. Do hold with this flexor with the clamp if necessary, or even K-wire fixations, the temporary fixation is mandatory. That is first. Then after that, we necessarily pass the guide wire. Placement of the guide wire is important, is that always we try to pass the guide wire in the center part of the neck and the head. This is called bull's eye. That means passing the screw, as I said, most of the time the entry point is lateral cortex. This entry point at the level of lesser trochanter is the entry point over here. Then make a point in the middle of these two. Then entry point should be always deal with a drill bit rather than the K-wire, I mean this guide wire. Guide wire may be doing, if it is doing so, this guide wire sharpness is lost, which is not desired. Sometimes there may be some sort of additional angle if you try more struggle. So it is better to make a bigger hole. That is essentially important, so that you can have this without difficulties. You can do some sort of manipulation on the guide wire if the hole is a bit big. After passing the guide wire, necessarily making the hole, we have to take the help of this your angle device, so as to place it there, so as to place it there like this and then pass the guide wire like this. Now once the guide wire is being passed in a halfway, and you can have a calculations from this C-arm that the trajectory is going to the center, that we are all happy. That means from the directions of the guide wire halfway, not at the up to level of the fracture side. If you find that the trajectory of the guide wire is going to be the center, we are all happy. You are not going to pass the guide wire straight. Now go to this CM in the lateral view. First AP view, it is entry, halfway, happy, go for the lateral view. Now in lateral view, two things may happen. Either the guide wire may go anteriorly or guide wire may go posteriorly. Now do the manipulations of the, because our AP view, our angle is fixed now. Now in lateral view, try to put the guide wire either posteriorly or laterally. Most of the time you try to make it or antiversions to be considered, so you have to do it like this and push it. Once it is pushed to the center, you have to reconfirm in AP and lateral view that your guide wire is in the center both in the AP and lateral view, which is called bull's eye. Once it is said that everything is okay. If the guide wire is not in positions, that is everything is going to fail. And to some extent it is said that you can do the guide wire bit inferiorly and posteriorly, but never superiorly. That is, if it is possibility of cut through is quite high. So little bit of inferior posterior is accepted, but never anterior and superior. So that is an important thing to be considered, and we all know that the guide wire is the main thing of this whole technique. If the guide wire is not placed properly, everything is not going to be right. So placement of the guide wire is the most important thing. We have anchors. People used to say one can pass the guide wire up to the AC level and anchor it so that you do not have any difficulty in doing so. After that, the reaming is to be done, and reaming is to be done. You see, you have a triple reamer. Why it is called triple reamer? It has three parts. One is for this screw, for this part, and for the barrel, this part, and this junction part is very important. Many times we have make a mistake that you do only reaming here, not going up to the base. If you are unable to reaming up to the base, what is the problem? Problem is that this angle is not going to be accommodated at the small hole. If it is no, if you hammer it, you can do it. There where you can break somewhere. That is not desired. This bone is very strong. So that is why while doing reaming, there is not to be done halfway, but you have to go up to the base and make this three part go in and make it heavy. Now, one point. Another point is up to what extent we are supposed to go to reaming. We are supposed to limit our reaming 10 millimeter subchondral bone below 10 millimeter below in case of your adult, and in case of your osteoporotic bone 5. So up to that extent, large span of this screw head at the subchondral area is very important thing. Shorter is never desired. So at the subchondral bone it is very strong one. In case of adult up to 10, in case of osteoporosis up to 5 is the ideal choice. So after reaming, what next? We are going to do the tapping. Tapping may not be essential in all the cases. In adult, young, strong bone, yes, tap is good. But in case of osteoporotic bone, probably tapping is not always essential. So after doing the tapping, we have to introduce this screw inside. And one thing is true that while doing so, one need to understand the meaning. One need to understand the meaning that why we are doing so. At the end, at the final tightening part, it is important to understand that if you are engaged there, you are engaged, at the final tight, you may find that it is, while doing the tightening, this fragment may also rotate along with it because it is engaged nicely. At this point of time, if you are not holding it nicely, or even with the temporary fixation, probably this fragment will also try to rotate along with the screw. This is more practical in case of left side rather than right side. Right side, if you are doing so, it is rotating downwards, so the chances is less. But in case of left side, it will go up, and there may be mismatch and also reduction. So it may not be an ideal reduction. So it may not be an ideal reduction. So that is why it is true that you need to push it in such a way that you try to engage it nicely, and that is why that last part is very important, because it is important that your slot should be like the horizontal to this body, parallel. Otherwise you may not. But if it is not like this, the plate may be like this. So that is not ideal. So it has a slot should be parallel, keep it like this, so that your plate may be introduced. Otherwise, if this slot is not like this, it may not accommodate this plate. So that is why that part is important to be considered, particularly at the end, at the final tightening, that it is always in this parallel to the long axis of the bone. That is another point. Then coupling of the plate. Now, after doing the plate introductions here, 2 to 3 things. One, which screw is supposed to fix first? We always supposed to fix the first final line. Why? Because if you are opening this part only, and if you do find the plate is lined, yes, we are all happy. Okay, fine, plate is like this. But you do not know the end of the plate, which may go for a bit high or a bit low also. So it may be situations like that. It may be sometimes high, or it may be eccentric. So to avoid this problem, what you have to do? You have to find out the tip of the plate, and also find out that whether it is in the center part of the body of the long femur or not. Then always try to fix the plate first here. Then do the other screwing here. So that is why it is always ideal in a DSS to go for the final last screw first, then the other screws later on. Number one. Number two, after supposing if you are doing a compression with the compression screw, before that, to have efficient compressions, what are the things we can do? We have to release the tractions here to have good traction and compression. 1 point. Number two, this screw is also going to give us the good compression to the 5 mm, as I said already. On the other hand, besides that, can the other techniques can help our compression? Yes. This concept, as I said already, this well screw hole is also helping us to do some sort of compressions at the compression side. So that is how we can achieve the compressions, static compressions over there. That 1 point is the relieve tractions there. To get the tractions, compressions there, we can take the help of these techniques. We can also take the help of the compression screw to have efficient compressions at the flexor side. So thereby we can completely jump closer up this. Now next point is that how to mobilize the sort of these patients. The mobilizations of these patients all essentially depends upon the quality of bone. 1 point. Number two is the how is the fixation you have achieved. If you are happy with the fixation, how is the feeling while you are doing the screwing and all the bones are quality, that reflects about the quality of the bone. Also the tactile feeling of doing the screwing and all maneuvers. That will give a judgment of these persons that how my fixation is. 1 point. Number two, you have to do the analysis of the X-ray later on to see the TED. TED is the factor, as I said, that is if your bull's eye is there, fixation is there, that is anterior and posterior and lateral view. If this bull's eye, the central part, there is nothing to worry about. And if you are identity principle. But TED is a factor that it is the tip apex, means apex and a tip from the anterior view and the lateral view, and summation of which is supposed to be lesser than 25. Smaller is better, but more is bad. So these points are coming up the post-operative evaluations of the X-ray of the patients, and then see how your device is. How is the contact of the fracture? How is the contact of the medial cortex? How is the quality of the bone? How is the fixation you have done? And what about the TED? So many, and also these personalities of the persons, that how he is going to help you of doing the manipulation, maneuver of the mobilization. If young adult, good fixations, you can start early walking. But on the other hand, if your fixation is not good, osteoporotic bone, and you are not very much happy with this medial cortex, and also that probably it is not good idea to start the person's early walking. So that this post-operative directions is not is actually tailor-made depending upon your fixations, your quality of bone, person to persons, and also the mobility, how he is going to work. So that is how you have to follow the whole procedures from the beginning to the post-operative period and subsequent follow-ups, and then you have to start doing the quadriceps exercises and other things to build up the muscles. Mobilization is very important. It is not essentially mobilization that's mainly walking. The mobilization from the bed is also important, particularly elderly patients. So the earlier mobilization is good for the patients, also better outcome. So that is how we have to complete the job, your DSS, and the techniques we have discussed. We have discussed about the fracture configurations, indication, contraindications, where not to do DSS is more important, or where you need to do, and the techniques, how we have to do the fixation step by steps. What is the importance of the guider? What is the importance of the reaming and other things to be done? And that is the how we step by step we have discussed, and that is how we are coming to the end of these discussions. And if you have any questions, you can ask. We will discuss the matter. Any doubt, we can discuss with you.